Good health requires a balancing act with blood sugar levels. Too high or too low are neither good nor healthy. The not-so-sweet life with diabetes. Tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. Diabetes is on the rise in the United States, and the results of uncontrolled blood sugar levels impacts our quality of life, causes other medical problems, and the financial burden grows exponentially. First, let's take a look at this week's Prairie Doc quiz question. True or false? Tight control of blood sugars with medicine and/or insulin increases in importance as diabetics age into their late 70s and 80s. True or false? Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answers in. But all evening, we will answer any of your medical questions about diabetes as they're called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight is Dr. Richard Crawford of Vera Medical Group Endocrinology and Diabetes in Sioux Falls. Thank you for joining us, Richard.
Thanks for having me, Rick.
So what does an endocrinologist do? And then where did that name come from anyway?
Well, so endocrinologists deal with glands and with hormones. And basically, we deal with some part of the body that secretes a hormone, like the pancreas making insulin, and then it works on some other part of the body and has effects. And so whether it's thyroid or, again, insulin from the pancreas, et cetera, that's our field. And diabetes is probably the majority of what we see. We certainly deal with other conditions, right, but the majority of what an endocrinologist does and works with.
Right. I remember they say there's the endocrine glands and the exocrine glands. Now, the pancreas is both.
Correct.
So explain that.
Right, so the endocrine portion would be that which secretes insulin and then sort of an anti-insulin hormone called glucagon. The exocrine portion is that which deals with digestion, so the enzymes amylase and lipase, for example, that digest food. And so the pancreas is actually two organs in one, but it's the endocrine portion that makes the insulin that is primarily important in diabetes.
Right. The exocrine part, as you described it, does it also make alkaline material to counter the acid that's made in the stomach?
Correct, yeah.
So that makes it such a tough organ.
It's very tough, yeah, very tough. Yeah.
So diabetes, it's on the rise. Is it on the same rise that obesity is?
It's interesting. They definitely go hand in hand. Back in 1980, there were 6 million Americans with diabetes. By 2016, there's 30 million Americans with diabetes.
Now say that again. 20 in 19?
No, only 6 million in 1980.
6.
So in 36 years, 30 million Americans, of which about a quarter don't even know they're diabetic. And that's been primarily a rise in type 2 diabetes, along with the rise in aging population, as well as the rise in obesity. But interestingly, type 1 diabetes is also increasing at a smaller rate, and we aren't quite sure why that is. Does it have something to do with the immune system? Is it related to allergies, something else in our environment? But both type 1 and type 2 are actually rising, but type 2, and along with the epidemic of obesity, is the real problem here.
All right. So let's talk about type 1 and type 2. What is the difference? I mean, it used to be one was childhood.
Right. So we used to call type 1 diabetes juvenile onset diabetes, or sometimes insulin-dependent diabetes. Now we call it type 1, but probably the better terminology would be autoimmune diabetes. And so autoimmune, where the body recognizes those islet cells that make insulin as foreign to it, they attack it, cause them to give out, thereby a patient needing insulin. And type 1 diabetes, although it's primarily in children, it can happen at any age. I once had a woman who thought she had type 2 diabetes, which we used to call adult onset type 2 diabetes. She thought she had type 2 diabetes.
Because she was an adult when it came on.
Right, she was adult insulin. She got it in her 70s, and the pills didn't work, and very quickly she was needing a lot of insulin. She also happened to have rheumatoid arthritis, which is an autoimmune disorder, and we did some blood tests, and we found out she had some tests that indicated that she really was a type 1 diabetic patient. She ended up going on an insulin pump, and she's done great.
The old story of where you had identical twins, one comes down with diabetes, and the chances of the other coming down with diabetes for the next year is like 50%, and then after that it goes back to the chance of anybody.
Right. So there's certainly a genetic component, but there must be something else.
Yes.
Whether it's an infection or some other trigger. And so type 1, again, we talked about is autoimmune. Type 2 diabetes, that's a disorder of insulin resistance, but also insulin deficiency and a lot of other problems. That's what we typically tend to see in elderly or older patients, also in people that are obese. But unfortunately, with childhood obesity, we're seeing children 9, 10, 11 with adult onset type 2 diabetes at the young age because of obesity, for example.
So the type 1 really doesn't make any insulin or doesn't have enough.
Eventually, right. There might be this so-called honeymoon phase where they make some for a while, but eventually the islet cells burn out, they can't make insulin, and they're fully insulin dependent. Type 2 diabetes, in contrast, at first they might be able to manage with diet and exercise, they might need pills. Eventually, when enough of the pancreas function is gone, they might need insulin, but they aren't truly the same as type 1 diabetes.
Okay, so 2 types. Now there are some we're hearing all the time of type 1 and 2. Which means,
or type 1.5. You might get someone who really doesn't fit in the picture, and sometimes we don't know the answer, and we can sometimes manage with pills, sometimes we need insulin, sometimes there's a little bit of both.
And we can talk about the types of new medicines, and we will later. And I want to jump into more questions about this, but we have a person who called in the question, the issue of the link between sleep apnea and diabetes. Do you see a link aside from obesity?
Well, there's concerns that when you have sleep apnea, that creates stress hormones. And one of those stress hormones, for example, is cortisol. Cortisol is a hormone that's released by the adrenal glands. And
when you're stressed out.
When you're stressed out. And certainly if you're stopping breathing at night and your oxygen goes down, what happens, your body tries to wake you up. It releases the stress hormone cortisol. Cortisol is very good at causing more weight to develop in the belly. You end up getting more insulin resistant, and so that indirectly can be a vicious cycle where you get more and more obese and then maybe even develop diabetes. So I think there is some truth that there could be a link there.
Well, I have seen a lot of diabetes raise its ugly head when I'm treating somebody with prednisone for a rheumatologic problem or whatever it might be.
Steroid-induced diabetes.
Steroid-induced diabetes.
Yep. Mm-hmm.
So, and then someone also asked about neuropathy. I'm going to go to the questions as they come. I've got an idea about where I was going to go, but let's take some questions.
That's okay.
Neuropathy, the numbness, the stocking glove numbness. The gloves.
The hands and feet.
It starts in the hands, starts in the feet, and it climbs.
Yep.
Right. This is basically peripheral neuropathy. That occurs with diabetes.
Very common as a complication in diabetes. When we talk about complications, we talk about what are called microvascular. So the little blood vessels are getting, if you will, clogged up with the sugar products. And so it's the eye damage, the kidney damage, and the nerve damage. When it's the nerve damage, we call it diabetic neuropathy. And typically, as you talked about, it's the stocking glove distribution where you start getting burning, pins and needles, numbness in your feet and hands. And it gets bad enough to where you don't heal up, and a smallest cut ends up being a big issue. I once had a patient who took his grandkids to the water park and he had neuropathy. He didn't know it was a hot day, was on the pavement, ended up with second-degree burns on his feet because of diabetic neuropathy. Yeah.
I've heard that all of the complications that come from diabetes is vascular, including, this is the theory, that microvascular feeding of the blood flow to the nerves is lost, and that's why you lose the feeling, particularly in your feet.
Right.
So if you've lost blood flow to your feet and you've lost feeling, you can walk around on a burning
and not know it.
Or have a pebble in your shoe. You wear a hole in the bottom of your foot, and then you don't have blood flow to fix it.
Right,
That's
exactly.
the
And you don't have those growth factors and all those things. You don't even sweat normally or make the skin oil, so your skin gets very dry and cracked, and that can lead to problems too.
We have another question that's kind of interesting to me in particular. Can ductal pancreatic cancer present as type 2 diabetes? In other words, cancer of the pancreas, tumors of the pancreas cause the body to present with diabetes mellitus.
It can happen. It is rare, but it can happen. And I would always raise that as a concern for someone who, for example, has newly diagnosed diabetes. Maybe it's very rapidly deteriorating. They've had unexplained weight loss, and maybe they don't have family history of diabetes. You know, when I get someone who's, at let's say middle age, and they end up with weight loss and diabetes, and nobody in the family was diabetic, maybe I'll check some of those antibodies to see if they're that late type 1 and they don't come out. I might want to look at the pancreas and scan it.
Antibodies. So you test for type 1 by seeing if they've developed an antibody against their own pancreas.
Correct. And so this is a useful test in someone where, again, it just doesn't fit the typical picture. I might see a patient who's in their mid-30s. Again, they're not obese. They don't have any family members with diabetes, and they come in and their blood sugar's 300, which is elevated. And maybe they've had a history of some thyroid issues, Hashimoto's thyroiditis. Maybe they've had vitiligo. They've lost their skin pigment. And so for those patients, I might want to check these glutamic acid or GAD antibodies, and glutamic acid decarboxylase or islet cell antibodies. And if they're elevated, I'm going to say, you've got autoimmunity. And even though right now you might be in the honeymoon phase, you're probably going to need insulin as time goes on. Oof. And whether that's full-blown need for insulin in 6 months or 6 years, we don't know, because the honeymoon phase can last a long time, especially the older one patient, an older someone gets. But it's something you have to think about. Or if you have someone you tried on pills and they're not working and you're scratching your head, start looking for some of those other things.
But that's interesting when you say honeymoon phase, and we need to go to this quick, but that's that where it looks like there's diabetes, things get better for a while, then...
Right, because sometimes what happens is when you present with a very high blood sugar, the pancreas kind of shuts down, you get medicine, it kind of wakes up again, but then eventually those antibodies kill it off.
Something's happening that's bad.
Yeah.
Maintaining a healthy lifestyle and being well educated about the disease are key to living a quality life with diabetes.
Controlling diabetes it's a lifelong thing. I mean, people can get to the point where they don't need medication for type 2 diabetes, but they still will have to be practicing those lifestyle habits like eating well and exercise. And so that's the second big part is how do we make sure that an individual can be able to manage diabetes on a day-to-day basis throughout their lifestyle.
The education part of it is crucial. Not knowing, what you can put in your body. It's not just cutting out candy bars. There's lots of things to it. Taking good care of yourself if you want to have a healthy lifestyle.
Typically what we focus on is timing. So how often a person is eating and meals and snacks and all that. And then a lot of it is carbohydrates. So managing those, not having too much, but not having too little at the same time. And so a lot of that is personalized. There tends to be some flexibility, and especially with the different medications out there and stuff like that, it does require personalization. And then finally, healthy eating. So choosing good quality foods, eating a variety of real foods.
Reading labels, that's a huge part of it. Again, some of the things that you take for granted every day will affect your blood sugars, and knowing that is first line of defense.
Watch out for sugary beverages. That would be a key takeaway that really seems, we see a big improvement if people are able to cut out like soda, juices, sugary coffee drinks, that kind of thing. And so that tends to be a key priority for a lot of individuals.
I like to eat. I'm a Midwest girl, farmer's daughter type thing, where this is what's for supper and you ate it, and there was no questions asked. So pushing food away when you may not be done eating is hard. But then again, you push that slice of pizza away and have a little salad, to offset that. Again, choices. Those are, again, you can sit down and eat the whole thing, but in the long run, it's not a good idea. A little goes a long ways sometimes. And just knowing once you once you are diagnosed with it, learning those things will help you, again, make a lifestyle change and to live a long, happy life.
You know, we really appreciate Callie and Leslie and their comments and discussion there. I mean, that's not easy to be under the video microscope. This is your show, and your questions are key to our show discussion. Call in your questions about diabetes to 1-888-376-6225 or send us an email to ask@prairiedoc.org. And we appreciate those questions. They just make everything better. Thank you for those questions. So you saw this particular comment. What's your sense about the value of a proper diet?
It's a backbone, really, of any sort of diabetes treatment. Whether you end up on medications or oral medications or insulin, the backbone is going to be a good diet. And really, I think it's important in terms of portion size, in terms of, I still say respect the food pyramid. 60 to 70% is carbs, maybe 20% is protein, the rest is fat. You know, maybe aiming for 60 grams of carbs per meal to 45, maybe no more than 75, 2 snacks a day of 15 to 30. Those are kind of basic principles. Obviously, you have to customize it for every patient, but a lot of it comes down to, I always want to tell my patients, you don't have to give up everything. I think we all should enjoy life, but it's knowing how to mix and match. It's knowing that, yes, if you're going to have a little bit of cookie, then it's got to be matched with something else that's not high in carbs. And some common things like a can of soda pop might be 39 grams of pure sugar. A bagel might be 60. That's kind of getting almost half of your whole meal right there. Right. So it's knowing how to mix and match it, basically.
They talk about an average meal should be like 700 calories. And if you can count calories, if you can you can pick up your
phone. There's
phone.
apps on the phone that
or
are free. And
ask your app person.
Right.
Hey Siri, how many calories are in this fast food deal? And we're looking at 700 max for a big evening meal, that type of a thing. And I like the idea of the value of non-starchy vegetables, probably the most important food that we can eat, that and fruit.
Yeah, there are a lot of them where you can get a cup or a half a cup and there's only 5 grams and
nothing in it.
And they kind of fill you up and you can make them tasty.
And they're good for you.
Very much so. Yeah.
So we have some questions about what are the symptoms of type 1 versus type 2? Can you define the symptoms of diabetes?
A lot of times the symptoms will overlap because, again, both type 1 and type 2 are by definition diabetes, and diabetes means high blood sugar. And so typical symptoms are going to be excess thirst, urination, blurred vision, perhaps weight loss, maybe a higher rate of yeast infections. Again, sometimes the neuropathy. Type 1 diabetes can sometimes be more dramatic, especially in children, where very quickly someone will get ill. They'll have rapid weight loss, very thirsty. There might be this fruity odor to the breath. This is what we call ketosis, correct. Mm-hmm. And that could be very dangerous. So, if you have a child or a loved one and they're losing weight quickly and they're very thirsty and they've got that fruity odor, get them in right away to be seen. Type 2 diabetes, a lot of times people will find it on a, life insurance physical, or, if they're lucky to maybe go up for an annual physical and get on exam. It can be much more insidious and present for much longer. But Sneaky, exactly.
You may not notice it. It's interesting. One of my teachers, when I was graduating from med school, just before I was doing a GI rotation, and my teacher did an oral exam on me, right? And his question was, so a lady comes into your office, she's like 15-year-old woman, and she's really short of breath, breathing hard and heavy and can't catch her breath, and you listen to her lungs. And so what do you want to do, Dr. Holm?
Right.
And I said, okay, I listened to the lungs. Lungs were clear as a bell. And the heart rate, 100, and Is any odor in the room? Oh, it smelled like fruit, you know, while it was diabetic ketoacidosis
Right.
because the ketones cause acid.
And she was trying to compensate by blowing off, you know, what we call respiratory alkalosis, try to blow it off and get it better.
Wow,
yeah.
great case.
Yeah.
Oh, but that's not common. But it's certainly one of the symptoms that you can get with type 1 when you get ketosis.
Right, exactly.
People are doing that same thing, though, when they completely take all carbohydrates out of their diet.
Right, that's called like a ketogenic diet, because if you have just pure fat and pure protein, your body is so starved for carbs, it's going to break everything down, and you end up with ketones, which probably suppress the appetite, but also probably not a healthy thing to do.
Yeah, not real healthy. I mean, you look at that acidosis, it's probably not a good thing. But you can tell them because they have that odor. I mean, you walk in the room and you go, you're on a diet, aren't you?
Yep, uh-huh.
What is the difference between diabetes mellitus and diabetes insipidus?
So one is sweet and one is less, you know, or dull or whatever. So some people say tastes great or less filling if you were to taste the urine, you know. And so diabetes insipidus is a disorder where you can't basically hang on to water, and it's due to a lack of a hormone called antidiuretic hormone. If it's from a brain source, sometimes there's a kidney way where it's resistant to it, and so what happens is you just pour out all your water. So if you were to test the water or the urine, it looks very clear. You're thirsty. You're getting up maybe every hour to drink, and that might be a disorder in the kidney, but also maybe with a pituitary or hypothalamic disorder. Diabetes mellitus, which is sweet, is the disorder of high sugar. When you get high sugar, that draws out more urine, and the urine again would be loaded with sugar, so it's sweet urine.
So the diabetes word means pouring out a lot of urine. Mellitus means sweet. Insipidus means
dull or like bland or something.
So
So if it's pure, if you're just urinating out pure water, it's a very dull urine. And then ancient Greece and Roman times, they would taste it, and that's how they'd make a diagnosis. Hard to believe, but it's true.
They did. I know that urine was the main diagnostic test that they had, so part of it was tasting it.
Right, or watching the flies, congregate over the sweet urine too. So.
Yeah. Could you explain the connection between heart disease and diabetes?
Very large connection. In
Yes.
fact, when we talk about diabetes, and we've touched upon the neuropathy and some of the other complications, the kidneys and the eyes, but really it's cardiovascular disease, heart attack and stroke, which is the biggest factor for diabetes. In fact, 80% or so of people with diabetes will end up having heart attack or stroke as a major cause of morbidity and possibly death. And so addressing not only the blood sugars but cholesterol, blood pressure, not smoking, exercising, keeping the weight down, all those things are very important because heart disease is integrally related to diabetes.
Well, I mean, it's vascular disease. I mean, the basic, all the blood vessels.
Right.
And some people say, well, what it does is it just accelerates the aging process.
It kind of does. It's sort of like internal rust, if you will. It's like you get all the sugar around, it gets oxidized, it's rusting you out. And so you want to reduce the rust products.
Right. And so explain, as long as we're talking about diabetes, and we talked about obesity, let's talk about why does obesity bring on or uncover diabetes?
Well, it's really
It's insulin resistance.
It's very complicated, but insulin resistance is a big component. And so what happens is not only are you obese, but a lot of times the obesity is all around the intestines and around the belly, what we call visceral adiposity or central obesity.
Belly fat.
It's
Apple.
It's the apple versus the pear. So your pear, you're a lot less likely to have diabetes than if you're an apple.
A pear is big hips and big legs.
Right.
Apple is big belly. Dunlap disease.
Correct, right. And so it's that which leads to insulin resistance and a whole host of other metabolic problems that then leads to diabetes. But it's not just insulin resistance. You also have to have some degree of impairment of insulin secretion in the pancreas. And so initially, someone will be insulin resistant, but what happens is eventually the pancreas can't keep up with insulin secretion. In fact, early on, those insulin levels are higher, but eventually they drop, and then the blood sugar goes up.
Right. I mean, so most of us with a normal pancreas could handle obesity. I mean, the obese
Right.
demands a lot more insulin. I mean, a lot more insulin.
Right,
But we
right.
can do it.
And there are certainly individuals out there that are very obese that are blessed without diabetes.
Because they have a fabulous pancreas
Right,
that's really
right.
cracking in and working
Right.
hard and doing the job.
Right.
We're talking about artificial sweeteners. People find artificial sweeteners in certain kinds of pop, but they can also artificially sweeten their cereal and so on and so forth. But probably the pop is the biggest.
Right, right.
Or soda, as people say in the South, or Coke,
Right.
as they say in the Southeast.
Yep.
Talk about the sweeteners, and when you have diabetes, how does it affect the body, and are there some sweeteners that are better or not?
Well, if you look at a lot of sweeteners, a lot of them are truly like what we call 0 calorie or 0 sugar. There's these so-called sugar alcohols where they've been modified and they've got the sweet taste, but they don't get absorbed, or at least, and I'm thinking like, what is it, like sorbitol, and
Oh, yeah.
I can't remember all of them by
Right,
name.
right.
But the bottom line is they probably are favorable to sugar, at least in terms of what it's going to immediately do with the blood sugar, because if it doesn't get absorbed, you aren't going to get the same thing. But I also think, and there's certainly theories out there, that it kind of gets the sweet appetite going, and it affects the brain, and you keep craving sweet things. So I always tell patients, I agree that limit your amount of artificial sweeteners, your sugar-free soda pops. I think water is by far the best. The other thing is some sweeteners like sucralose in many people can be very much like a laxative. And so all the patients where they'll all of a sudden go, they're newly diagnosed, and maybe they'll go on all these like sugar-free candy, sugar-free ice cream, and like, my blood sugars are good, but I've got the runs, and it's like, well, it's all your sugar-free stuff. So a lot of them are not very well tolerated. Some I think can cause headaches. So, I think you have to be careful with what you do with artificial sweeteners. And I still think it's better to if you like sweet, get a healthy maybe fruit that's also loaded in antioxidants. There's other beneficial properties, and try to go that way if you need that little sweet.
I have looked at this and analyzed this, and Consumers Report really went into all of the different sweeteners, and there's some concern about when you did aspartame, the blue sweetener, that the rats would get cancer.
Right.
But they found that Splenda, which is there's several other brands of it, and there's a generic, and it's cheap, is the better and the safer one, and so I've turned to that one when I do my cereal. But for the most part, I try not to add any of that, and I certainly don't drink a ton of diet anything.
Right. Water is your
Water's
best.
a good
Water is
good
your
option.
best friend. Yeah.
So 2 bananas a day affect someone's diabetes? Or are there any herbal things that can help diabetes?
Well, bananas are pretty starchy, and so if you have a large banana, that small banana might be 18 grams, a large could be as many as 30. So you just have to, figure into how that's going to work.
How many calories
And
it's
so
got.
I might stick with a half or maybe 1 and maybe not 2. Also sometimes with diabetes, especially if you have it more advanced and you have kidney problems, you could have problems where you can't get rid of the potassium, and so you have to go on a lower potassium diet. We all know that bananas are very rich in potassium, and so
Well, a lot of fruits are. Really.
right,
Dried fruits.
a lot of fruits, prunes, things like that. So I think while it's good, I'd say everything in moderation. I love recommending like the blueberries, the blackberries. Those are kind of lower,
Heavily colored.
Yeah, right, and they're loaded with antioxidants. Those to me are healthy choices.
How about cinnamon? People talk about cinnamon and other kinds of
Right.
spices. Do you have any recommendation about that?
So actually there are 2 kinds of cinnamons. One is Chinese cinnamon, one is Ceylon cinnamon, and they're kind of different things.
Didn't know that.
But yeah, cassia, I can't remember the Latin name. But anyway, cinnamon, they have shown that there are some properties for insulin sensitivity and maybe in diabetes. A lot of the research has been done in India, for example. But when they've done what they call meta-analysis, where they look at all these studies together, they haven't found conclusive evidence that it really would be, for example, a substitute for something else. But I do think it's been shown that there are some hyperglycemic properties, some blood sugar lowering properties that I think if you like it, it's not a bad thing.
So which one was the better one?
I think the Ceylon cinnamon is the one.
And
Yeah.
you can find that? I didn't know.
I don't know. You have to probably order it.
I
so.
remember that there was a particular study that looked at artificial Coca-Cola and and they found that the people who were drinking those were no different than the people who are drinking the sweetened.
Yeah.
It doesn't work. It
Right.
seems to drive you.
Right. I still think when you think about if you love your regular Mountain Dew or regular Coke, that's a lot of pure, fructose or sugar, and so I think cut that down if you really have to have the sweet diet. But again, I agree. I think you don't want to drive the brain to seeking sweet all the time,
Yeah.
and I think sometimes you can modify it if you find other things.
Yes. Staying informed about the disease makes it possible to live a healthy life with diabetes. The best results often involve everyone on a patient's healthcare team.
Throughout diabetes education classes, we give the patients with diabetes the knowledge and tools to live a healthy life with diabetes. When a person comes to diabetes education appointment, we offer individual appointments or class sessions, and we cover a variety of topics of education, such as glucose monitoring, insulin education, diabetes pills information, sick day management, exercise.
I think one of the most important things that we also do as educators is partner with providers so that the nurse, the dietitian, the physician, and PPA work together to help the patient live a healthy life and understand how they can incorporate diabetes.
We encourage patients with diabetes to participate in aerobic activity to help control glucose levels, such as walking, jogging, riding bicycle, swimming.
As diabetes educators, we encourage people to do anything and everything that they want to. Diabetes does not have to limit a person at all. But it's really important to control blood sugars because diabetes can cause some long-term problems. Diabetes can affect the eyes. Diabetes is the leading cause of blindness. Diabetes can also affect the kidneys. Diabetes is the #1 reason that people need kidney dialysis. It can also affect the nerves and the circulation. People with diabetes are 2 to 4 times more likely than someone without diabetes to have cardiovascular disease. So all of those things are obviously things that we want to prevent, and people can prevent by controlling their blood sugars.
Diabetes education appointments are important in addition to the doctor appointments. It allows for more time for the patient with diabetes to ask questions and gain more knowledge about control of type 2 diabetes.
Medicare, Medicaid, and most private insurances do cover diabetes education. So it's important that the patient has a referral from their provider to get a diabetes education visit. One great way for people in South Dakota to find out where diabetes education programs are located is to go to the South Dakota Diabetes Coalition website, and that's sddiabetescoalition.org. And there's an interactive map that people can click on their region and pull up a list of all the education programs in their area. Once the educators have the referral from the provider, then they call the patient to schedule an appointment.
It's obvious that no matter where you live, there are diabetic education resources near you. So why would you encourage people to have a diabetic educator? How important are those people?
I think it's highly important. Really, when you think of managing diabetes, it's a team approach. It's the patient, the healthcare provider, whether it's a physician or physician assistant, it's the dietitian, the diabetic nurse educator, because really, it's not like you're going to learn it all at once. It's an ongoing process. It's also getting that motivation, and let's face it, it's a tough thing to have to keep doing day in and day out, and sometimes it's just good to get back in and have a pep talk and say, okay, I learned how to do this, but maybe I need to do this as well too.
Yeah. Or I'm having these funny little symptoms. Could that mean? And that whole issue about how tight of control.
Right.
So let's talk about that. I mean, of course, for a longest while we were being evaluated, physicians, care providers, how well we're doing with our diabetic patients. If we've got our patient down to the lower hemoglobin A1C, which is a measure of how well your sugar is over 3 months. But we found that we get too low, and the death rate go up again.
Right, right.
Explain that.
Right. Well, and so the American Diabetes Association says an A1C of 7 or less. The American Association of Clinical Endocrinology says 6.5 or less. So that you might hear these numbers thrown around, 6.5, 7. And for some patients, when they did studies, there was a big study called ACCORD, another one called ADVANCE, they had tighter and tighter control, and at first they did better, but when it got too low, they actually started seeing higher rates of complication, including death. And if you take someone, for example, who's elderly, frail, maybe they've had pre-existing heart disease or a prior stroke, I wouldn't want their A1C down to 7 or less, because to do that, maybe they're on insulin, that by nature will give them some hypoglycemia. Low blood sugar sometimes could be far worse than a mildly high or high sugar. And so you have to individualize it. And I think the ADA has recognized that you must do an individualized approach. Someone who's got very few other complications, they're young, we work for tighter control. Someone who's closer to the end of their life and has other problems, you don't have as tight a control. I have a patient who's 94, and I'm very happy, if his A1C is between 7 and 8, or even 8 to 8.5, because I know if I try to drive it too low, he may have a hypoglycemic reaction.
It'll kill him.
He may fall down, break a hip. Hit his head, it'll kill him.
Isn't it interesting that a lot of physicians are being evaluated by, insurance companies,
right.
Government, whatever it might be, to say, okay, and somebody's made a rule. This is the
Right,
rule. You've got to
right.
do this, and it causes more harm than it does good. Because what we really need to do is to individualize with every patient.
Right.
Every
One size does not fit all. You
No.
have to individualize
in
it.
every disease.
Right, right. And very much so in diabetes.
Very much so in diabetes.
Yeah.
What do chemotherapy drugs for breast cancer do to a pancreas to cause diabetes? Chemotherapy ever bring on diabetes?
I can't speak to individual components, but I do know that there are various agents that could be toxic, to cells, including with, the pancreas. And for example, in a lot of medical research, they would take laboratory rats and they would give them a substance to kind of create them to become diabetic. And I hate to say it, I think chemo probably can act the same way.
Yeah.
And so anytime you're under a certain regimen with that, and certainly a lot of chemotherapy use very high doses of those corticosteroids. We talked earlier about
Right.
cortisol and prednisone. Well, they might get a huge dose of Decadron, which is a very powerful steroid. That alone sometimes can induce diabetes.
Yeah.
So even if you're not diabetic or if you're pre-existing diabetic, you have to be vigilant if you're having to
Right.
undergo some chemotherapy.
So I was getting chemo every 2 weeks, and horribly toxic, GI toxic drugs. But part of what they did to keep me from being ill, and for many patients who do the same thing, is that huge dose of steroid,
Right, right.
which throws you for an absolute tizzy.
You're wired
and
and-
you're wired, and then you come off of it in day 3 or 4. So
Right.
it's this roller coaster thing. But your sugars are one of those things that would obviously get worse with certain chemotherapy.
And certainly with your physician, because they can go so high, make sure they know, whether it's your endocrinologist or primary care provider, that they know what you're going to be undergoing, so they
Right.
can kind of plan ahead. And sometimes I have patients who might start on just pills where we have to add insulin for that purpose. And then once they get through the chemo and past the
Right.
steroids, they can come off the insulin.
We love the questions. Thank you so much for calling. Can muscle spasms, painful cramps, be a result of neuropathy and type 2 diabetes? Muscle spasms, you've seen that with diabetes?
I see a lot of muscle spasms and cramps with diabetes, and I don't know if it has to do with potassium or magnesium. I don't think we entirely know what that is.
I
but-
love that answer, because I have gone my whole life trying to take care of people with muscle spasms, and I've heard people say, "Oh, if I take calcium, it goes away." I've had people put soap underneath their mattresses. That works every time. They
Tonic
say
water with little quinine.
Yeah, a little
sometimes.
quinine.
Yeah.
I used to treat a lot of people at Emory, at Grady Hospital, with quinine tablets
Right.
before they went away.
Right.
But what I have found is that people who are starting to exercise, they're finally getting out, doing the exercise that they're supposed to do, then their muscles go into spasm at night.
Right.
And so the best treatment is, make sure that you gradually start
And
exercise.
stretch.
And then
do a-
stretch before
right.
bedtime.
Right.
That's it.
Yeah, that's probably good. But definitely, I would say, anecdotally speaking, that spasms and muscle cramps in Charlie horses are more common with diabetes.
And is it maybe fluid switches too?
It might be, yeah. You know, I again, I don't necessarily, I don't think anybody truly knows.
Good answer. Is there a correlation between function of mitochondria and autoimmune disease? Also heard Alzheimer's disease referred as type 3 diabetes. Is that true? So mitochondria and autoimmune disease, explain those.
Well, that might be above what I can explain, but in simple terms, mitochondria are like the engines of cells,
cell.
right? And so if there's something that affecting that can cause cell death, or what we call apoptosis. And as cells knock out, you know, you're going to have problems. You know, we do know that with diabetes, so-called, you know, any diabetes, that there is a higher rate of memory loss, and whether that relates to low sugars or high sugars, and
Or vascular
disease and plaques that form in the brain. So there is a higher rate of dementia with diabetes. As far as this type 3, you know, it's again, you have to. Diabetes, by definition, has to be with elevated sugars, and if there aren't sugars, that's at the cellular level. I'm not saying it doesn't exist, but how do we quantify it? But I do think it's a fascinating subject, and you know, we need to do more research as far as what's the link between inflammation, between glucose metabolism, energy metabolism in the brain. You know, those are all interesting areas.
I mean, we just don't know what Alzheimer's disease is at this point. I mean,
we don't.
You know, type 3 diabetes. I've never heard that one. I do think that it runs with vascular disease.
Right,
You know, the higher risk of vascular disease, so goes at Alzheimer's, although they're different.
Right.
But they seem to run together.
Right, vascular disease and inflammation. of
Yeah,
some sort.
inflammation.
Yeah.
Do all diabetic patients eventually end up on dialysis? There's a good question. Dialysis is kidney failure, right?
Right. You know, unfortunately, you know, diabetes is one of the leading causes of kidney failure, along with hypertension, high blood pressure. But it's not inevitable. I mean, again, that is where
not, is it?
It's not inevitable. I've had patients who got the Eli Lilly Gold Medal Award for 60 years of type 1 diabetes. You know, these are people that were diagnosed back in the 1940s, 50s. Teenagers, you know, when they had old beef and pork insulins and had to, you know, grind the needles and boil them, and you know, maybe if you were lucky, you could test the urine, and you know, we didn't have glucose meters. They had old technology, but you know what? They really, with the technology they had, they took care of themselves. And after 60 years,
Still doing well, no kidney failure.
no kidney failure, maybe some eye issues, you know, because that seems more common, but not necessarily kidney. Right?
Wow. Do cholesterol and hemoglobin A1C have anything in common? He had heard a rumor that taking metformin would lower your cholesterol, and a cholesterol medication could lower blood sugar levels. So is there a commonality between cholesterol and diabetes?
We do know, I think, that if you are uncontrolled with diabetes and you get better control, a lot of time the whole cholesterol will come down as well. Certainly triglycerides, which are one of the components of cholesterol, are very strongly linked. You know, if I have someone who has very high triglycerides, we will get the diabetes under control, and it'll improve even without medication.
They talk about metabolic syndrome. Explain that.
So metabolic syndrome, or syndrome X, is again the disorder where you have central obesity, lipid, you know, or what we call cholesterol disorders, oftentimes low HDL, which is the good cholesterol, maybe high triglycerides, hypertension, and risk of heart disease. So it's sort of if you will, a precursor. You can have metabolic syndrome and not have diabetes. You can have metabolic syndrome and eventually have diabetes. Right. But sometimes I like to think of it as like a pre-diabetic condition. But it's a risk factor for diabetes and for heart disease.
That group has a high risk for sleep apnea, and that group will be the most benefited by an exercise program.
Absolutely.
Wow.
Right.
Please talk about non-insulin medication, Trulicity, for example, or for type 2 diabetes. What about, and this is type 2, medicine for diabetes.
Right. With type 2 diabetes, we have a whole host of not only insulins, but oral agents and these non-insulin injectables. Trulicity that you mentioned is what's called a GLP-1 receptor agonist. Right. And so in our gut, we normally make a hormone called GLP-1. like insulin, that hormone is deficient in folks with diabetes. And so, and what's interesting is the very first one they got from the venom of a Gila monster.
Yeah, isn't that amazing?
Exenatide, right? And
Byetta.
Correct. And so, the natural form, you can't do it because it only lasts for a few minutes. You'd have to be hooked up to an intravenous solution.
Gila monster right there.
Right, there you go. So you have to do these things in injections. And so there's a couple that are once a week, Bydureon and Trulicity. There's Victoza, which is a once a day. We've got Byetta twice a day. So we've got a variety of some
And I
other new
love
ones.
those because they help lose weight as well.
Correct,
So
right.
you put metformin and the second drug, Bydureon. These people do really well.
Right, and so you always background, as we said, diet and exercise, then metformin, and then something like one of these injectables. If someone's really squeamish about injectables, there's some newer medicines, what are called these SGLT2 inhibitors.
Where they pee out the
Right,
sugar.
right, like Invokana, Jardiance, Farxiga, whereby you inhibit glucose reabsorption, you end up in the kidneys, and so you end up excreting, an extra 70 to 100 grams, which could be up to 300 or 400 calories a day, and so that lowers sugars and also helps with weight reduction.
Right, some new improvements. The problem is they cost so much. Taking 18 units of insulin in the morning, 10 at night, and wondering if they're swallow tablets rather than take the shots.
It depends. So if that's someone who is has type 1 diabetes, there really is no option. If you're type 2, diabetes, those don't sound like huge doses. But then the question is, why aren't you on anything else like metformin or, one of these other SGLT2s? And sometimes you're limited if you've got some kidney insufficiency. So metformin does not cause kidney damage, but if you have poor kidney function, it builds up like a toxin and you can run into problems.
Got to be careful with the dose.
Correct.
Metformin over a long time caused B12 and magnesium deficiency?
Very good question. Yes, there is a known link, and we started out with talking about neuropathy, and sometimes if I have a patient who comes in and they say, all of a sudden I've got tingling in my feet, I might want to check a B12 level, because if they're on metformin, that can leach out B12, and they may end up needing to supplement that.
Although I will tell you this, I do check their B12s, but I put them all on 1,000 of B12 anyway because our levels aren't always that good.
Right. It probably wouldn't hurt.
And then Dexcom continuous glucose monitoring.
Yeah. So what that is, it's a device that basically you insert under your skin, and it's got a sensor, and it beams to a wireless device, and it senses your sugar every 5 minutes, and so it can alarm if you go high and low. It's really a godsend, for a lot of patients, especially a lot of type 1 patients.
Type 1 diabetic for 38 years, family is prone to cancer, being a diabetic for this long, having a natural deterioration. What's his chance of pancreatic cancer?
We would probably say we don't know.
Probably normal. I don't sense that they're
I wouldn't think to necessarily look, unless there's some other genetic factor.
High fructose corn syrup cause diabetes?
I think less of it's better.
Yeah, I think the major thing is more non-starchy vegetables, less calories. Become a calorie counter.
Right, and all those things that are just a big punch of a high glycemic index, refined starches, high fructose corn syrup.
Potatoes.
Stay away from those.
Too many potatoes. You can have a little.
In moderation.
In moderation.
Right.
Yeah. Okay, and I need to get we want to go back to the quiz question, and it says, true or false, tight control of blood sugars with medicine or insulin increases in importance as diabetics age into their late 70s and 80s? You want tighter control when you get older?
Typically no, so I'd say false.
False. The answer is false. It's always important to have reasonable control of sugar, but low sugars are particularly dangerous for the elderly. And so our goal for the elderly may be less tight, depending on each situation. Talk to your doctor. And it was Janet Welch who answered the question correctly. Thank you, Jeanette. From Parkston, it's Jeanette. Thank you for Parkston for participating. A book will be in the mail to you soon. We'll be right back after this.
All around town, from stores to playgrounds, babies are on the move. And there are diseases that are on the move too, and some of these spread easily. To best protect him from 14 serious diseases by the time he turns 2 years old, vaccinate him according to the recommended schedule, so he can go on about his business and you can have peace of mind. For more reasons to vaccinate, talk to your child's doctor or go to cdc.gov/vaccines.
Testing for diabetes started a long, long time ago. The word diabetes comes from ancient Greek, which literally means pass through, intended to mean the excessive passing of urine. This characteristic of too much urine was first described 3,500 years ago on an Egyptian papyrus. About 1,900 years ago, Roman physician Galen called it diarrhea of the urine. The reason for so much passing of urine with diabetes mellitus is because high levels of sugar in the blood overwhelm the kidney's ability to keep sugar out of the urine. Like a dam on a river, sugar spills over the dam into the urine when sugar gets too high in the blood. And then, with concentrated sugar in the urine, fluid is pulled out of the blood into the urine, resulting in dehydration of the diabetic. Indeed, the name diarrhea of the urine seems appropriate. About 2,500 years ago, someone noted flies were attracted to the urine of diabetics. Tasting urine for sweetness may seem disgusting today, but it was how they diagnosed diabetes all the way through the Middle Ages. It was English physician John Roll in the 1700s who added mellitus to the term diabetes to reflect the age-old understanding of the sweet taste of the urine in diabetic patients. The word mellitus comes from Latin, meaning sweetened with honey. Starting in the 1950s, patients roughly estimated the level of sugar in their blood by testing their urine with a chemical test they could do at home. By defining how much sugar spilled into the urine, people with diabetes mellitus were better able to adjust their insulin dose. Home urine glucose testing was an improvement for patients with diabetes, but home blood glucose testing, developed in the 80s, took us to the next level. Patients could finally know when sugars were too low, not just too high. Another great improvement in monitoring sugar in people with diabetes was the discovery of the hemoglobin A1C blood test. The hemoglobin molecule within red blood cells becomes more sugarized, the scientific word is glycosylated, when it has extended exposure to higher levels of sugar. Since red cells normally live about 3 months before the spleen removes and destroys the old red cells, this allows measuring the percent hemoglobin affected by sugar to change slowly according to diabetic control. The hemoglobin A1C levels give a 3-month average blood sugar, which gives you and your care provider a good measure about how well you're controlling your diabetes over time. It's a good thing managing diabetes no longer requires tasting urine. A big thank you to our guest, Dr. Richard Crawford. Thank you so much, Richard. We are grateful that he agreed to give his time to join us this evening. His insight was invaluable to our discussion. Did you know that South Dakota has the 3rd highest fall rate in this country? It's sadly true. In 2015, there were 181 deaths following a fall in South Dakota. 85% of fall deaths associated with home or residential institutions. Among other precautions, care providers for older patients may want to monitor or reduce medications that affect balance and increase the falling risk. Here at On Call with the Prairie Doc, our staff and crew work to provide honest, science-based information aimed to help you make good healthcare decisions. If you believe in our efforts providing good information in a world of a lot of misinformation and would like to help continue this quest for trustworthy, real information, please go to prairiedoc.org and click on the donate button. Any help you can give will be put towards providing authentic information to thousands of viewers. Thank you. That does it for tonight from all of us here at On Call with the Prairie Doc. Until next time, stay healthy out there, people.
We diet, we exercise, or we have surgical procedures, but how well do they work? How can we keep weight off that we have lost? Bringing balance to obesity. Next time, On Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota, and with the ongoing support of these individuals and institutions: Brookings Health System, Ophthalmology Limited, South Dakota State Medical Association, Avera Heart Hospital, Dakota Allergy and Asthma, Fishback Financial Corporation, Vance Thompson Vision, Aberdeen Asthma and Allergy, Black Hills Medical Society, Aberdeen District Medical Society, Dakota Bank, Orthopedics Institute, Physicians Care Sanford Clinic Community Service Committee, Swiftel Communications.